Hi, everyone. My name is Farzad Moazed. I'm one of the pulmonary and critical care medicine physicians at Highland Hospital in Oakland. And today I'm going to be talking about prone positioning in ARDS. The learning objectives for this talk are for the viewer to understand the effects of prone positioning on respiratory physiology, to learn the evidence behind why we use prone positioning in certain ARDS patients, and to know the contraindications to prone positioning. In order to understand the potential benefit of prone positioning in ARDS, it's important to first understand the effects of body position on respiratory physiology. And I've borrowed this nice figure from UpToDate to help us do this. So first, let's start out by discussing what's happening to respiratory physiology and mechanics in the supine position. So in the top half of this figure, with the patient in the supine position, you can see that the heart is resting on part of the lung and compressing those portions of the lung. In addition, the entirety of the weight of the abdomen is compressing portions of lung and also causing the diaphragm to move cranially, further causing lung compression that way. These effects are exaggerated in patients with ARDS because the weight of the lung is actually higher due to the edema fluid that has accumulated in the lung. So what you get is essentially collapse of your dorsal alveoli because of all the excessive weight and compression that's occurring, with not really nearly as much compression of your ventral alveoli. And so when a tidal breath is delivered, that air is going to go preferentially to your ventral alveoli. And that's going to result in overdistension of those alveoli and ultimately can lead to ventilator-induced lung injury, worsening outcomes. Furthermore, this unequal distribution of ventilation becomes a problem because we know that blood perfusion is actually highest in the dorsal portions of the lung, and that's irrespective of body position. So even when you're in the prone position, the dorsal portion of your lung is going to actually have higher blood flow. And so when you're in the supine position and your ventral alveoli are getting most of the ventilation, with your dorsal alveoli getting the most of the perfusion, that's going to be a problem because it's going to lead to poor VQ matching and can lead to bad oxygenation. So how does proning a patient help? Well, on the bottom half of this figure, you can see a proned patient. And the first thing we notice is the heart is no longer resting on the lung, it's resting on the sternum. So that weight is removed. And some of those units can be recruited. In addition, the abdomen is no longer compressing things. The diaphragm can shift caudally, resulting in decreased lung compression. And although you have some relative compression of ventral alveoli while in the prone position, this is far less compression than you see with the dorsal alveoli in the supine position. And as a result of that, you're going to have a more equal distribution of your tidal volumes, and you're going to have more overall recruitment of alveoli throughout the lung. The other thing you will get is because now your dorsal alveoli are being much better ventilated in the prone position, and your blood flow is higher in the dorsal part of the lung, you're going to have better VQ matching there. And all of those work together essentially to lead to improved oxygenation. So the question is, we have improved oxygenation, or we think we see mechanisms for improved oxygenation. Are we actually going to see improvements in patient outcomes? And the answer to this is probably yes. Now, there were some smaller trials done before the trial that I'm showing you here, but I'm really going to focus on this one, the PROSEVA trial that was published in the New England Journal of Medicine in 2013, because it's really the largest randomized controlled trial of prone positioning, and it really has driven our practice today. So this was a randomized controlled trial of 466 patients with ARDS. Their PF ratio had to be less than 150. FiO2 had to be at least 60% on a PEEP of at least 5. It's important to note that all patients received a low tidal volume ventilation strategy. A few earlier studies prior to this did not necessarily incorporate a low tidal volume ventilation strategy and did not show a benefit. So it's important that you're always doing this in conjunction with low tidal volume ventilation. Patients were proned manually for at least 16 hours a day, and this was done relatively early in their admission. So this is not a late thing that we should be doing. It should be done early once they're hitting the right parameters. And this was continued every day until patients achieved a PF ratio greater than 150 on 60% or less of FiO2 and 10 or less of PEEP for at least 4 hours after being put back in the supine position. And what this study found was that the prone group had superior probability of survival compared to the supine group. And if you look at the crude mortality rates, the supine group, 33% died, whereas only 16% died in the prone group. And those were statistically significant differences and quite large differences as well, as you can see. There are a few caveats to this study. Firstly, the control group was actually sicker at baseline, despite this being a randomized controlled trial. The patients who were in the supine group had higher SOFA scores, more organ dysfunction, more vasopressor use as well. So it's unclear if some of the effect that was seen with proning was due to these baseline differences. In addition, there were a number of adjunct treatments that were used in this study. A large percentage of patients were on paralytics, and a smaller percentage, but still substantial amount of patients were on steroids. And those were not equally distributed between groups, so there may be some confounding from that as well. However, subsequent meta-analyses are consistent in showing a benefit in mortality when this is used in the sickest of patients. So this is a study that was published in 2014, a meta-analysis stratifying by PF ratio. So in the top third, you see PF less than 300, middle PF between 100 and 200, and then at the bottom, PF less than 100. And you can see from this plot that the effect is really strongest in patients with PF less than 100 and is most favored in those patients with severe ARDS. Similarly, this meta-analysis published in 2017 on the left shows that the effect is stronger in patients with moderate to severe ARDS as opposed to all comers with ARDS. So this is really a treatment that we want to be reserving for patients with moderate to severe ARDS. The other thing that's important to note on the right is the duration of proning per day. And this is important to highlight that if you're not proning for a sufficient amount of time per day, you're less likely to see a beneficial effect. And here, when they found that there was less than 12 hours of proning daily, there was really no benefit, whereas when they were above that threshold, that's when we began to see the benefit. How are patients proned? At Highland and in the New England Journal of Medicine study that I highlighted, patients were prone manually. We prone manually, and our protocol can be found on the AHS intranet. If you're interested, you can also view the New England Journal of Medicine video on YouTube. Some institutions are using rotoprone beds, which you can see on the right, where patients get strapped in and essentially are rotated almost like a rotisserie. Those have not been used in any large studies and tend to be expensive, but in theory, they should be effective. So what are the complications of proning? So there are several complications to look out for. The first are complications related to the ET tube. It can become obstructed, it can dislodge, So just being very careful during that process to ensure that doesn't happen. Loss of IV access is also something that can occur. You can lose central lines, arterial lines, peripheral IVs. So paying close attention to those. Also making sure that even if they don't come out, that they're not getting compressed and that key medicines that are running through them are not getting obstructed. You don't want a line that's running a vasopressor to get kinked or blocked, and all of a sudden that vasopressor doesn't run for 15 minutes and you didn't notice. Hemodynamic instability can also occur, so watching carefully for that. And then patients in the prone position have higher incidence of vomiting compared to the supine positioning, so just being aware of that possibility. Finally, we'll talk about the contraindications. So pregnancy, due to the position of the fetus, is a contraindication to proning a patient with ARDS. Patients with refractory shock should not be proned. That doesn't mean if they're on a vasopressor, they can't be proned. That's okay. However, if they're on vasopressors and despite that, they're still in refractory shock, those patients are probably not stable enough to be proned. New or certain cardiac devices, fresh pacemakers, VADs, balloon pumps, those patients should not be prone. If you have any burns, wounds, or chest tubes on the anterior portion of the patient, that's a contraindication to proning. Spinal instability and big unstable fractures, like for example, pelvic fractures that are not stable, are contraindications because we don't want to be moving those patients around as much. Because of potential effects on ICP, if a patient has increased ICP to begin with, they should not be prone. And finally, if a patient has had recent tracheal surgery, that's a contraindication to proning. So the take-home points here are that prone positioning really works to improve VQ matching, particularly in ARDS patients, likely leading to improvements in oxygenation and mortality in patients with moderate to severe ARDS. It's key to ensure that you're doing an adequate duration of proning every day and only cutting that short if complications are developing. And this should also be done in conjunction with other strategies, including, of course, low tidal volume ventilation. Finally, always make sure before you do this, you're assessing for contraindications, making sure the protocol is followed very closely, and watching carefully for complications that might develop. Thank you.